Question 1. The performance metrics show a slight increase in the time taken to initiate interventions for pediatric patients presenting with moderate respiratory distress. A 4-year-old child arrives in the emergency department with audible wheezing, increased work of breathing, and mild cyanosis around the lips. The child's parent is visibly anxious and states the child has had a cough for 3 days. The nurse needs to act swiftly to manage the child's respiratory status. Which of the following actions best reflects the immediate nursing priority and professional practice in this scenario? Option A. Administer oxygen and initiate nebulized bronchodilator therapy while reassuring the parent and obtaining a brief, focused history regarding the onset and duration of symptoms. Option B. Delay oxygen administration and bronchodilator therapy until the parent provides a written consent for treatment, as the child is not in immediate life-threatening danger. Option C. Immediately begin a detailed questioning of the parent about the child's complete medical history, including allergies and past hospitalizations, before administering any treatment. Option D. Focus solely on the child's physical assessment and initiate interventions without acknowledging or speaking to the parent until the child is stabilized. Correct answer is A. Administer oxygen and initiate nebulized bronchodilator therapy while reassuring the parent and obtaining a brief, focused history regarding the onset and duration of symptoms. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the pediatric emergency nurse to balance immediate patient needs with established protocols and the need for parental involvement, all within a high-stress environment. The nurse must assess the situation rapidly, prioritize interventions, and communicate effectively with both the child and the parent, while adhering to legal and ethical standards of care. The potential for misinterpretation of a child's distress or a parent's concerns adds complexity. Correct approach analysis. The correct approach prioritizes immediate, life-sustaining interventions while simultaneously seeking to involve the parent in a supportive and informative manner. This aligns with best professional practice by addressing the ABCs: airway, breathing, circulation of pediatric emergency care, which is a fundamental principle in emergency nursing. Furthermore, involving the parent, when appropriate and safe, can provide crucial historical information, reduce the child's anxiety, and fulfill ethical obligations regarding informed consent and family-centered care, as often emphasized in pediatric nursing guidelines. This approach respects the child's vulnerability and the parent's role as a caregiver. Incorrect approaches analysis. One incorrect approach might involve delaying essential interventions to fully obtain parental consent or detailed history, even when the child's condition is unstable. This fails to uphold the paramount duty to preserve life and prevent further harm, violating the principle of beneficence and potentially leading to adverse patient outcomes. It also disregards emergency protocols that often allow for implied consent in life-threatening situations. Another incorrect approach could be to proceed with invasive procedures without any attempt to inform or involve the parent, even if the child is conscious and able to communicate their distress or the parent is present and calm. This could be seen as a violation of patient autonomy for an older child and parental rights, potentially leading to ethical breaches and legal challenges. It also misses an opportunity to build trust and provide comfort. A third incorrect approach might be to dismiss the parent's concerns as secondary to the medical assessment, thereby alienating the caregiver and potentially missing vital subjective information about the child's condition. This demonstrates a lack of respect for the family unit and can hinder effective collaboration, which is crucial in pediatric care. It fails to recognize the parent as a valuable source of information and support. Professional reasoning. Professionals should employ a systematic approach that begins with a rapid assessment of the child's airway, breathing, and circulation. Simultaneously, they should assess the parent's demeanor and ability to provide information or support. Interventions should be initiated based on the severity of the child's condition, with communication and parental involvement integrated as much as the clinical situation allows. If the child's condition is critical, life-saving measures take precedence, but communication with the parent should be ongoing and as clear as possible. If the situation is less acute, a more thorough history and explanation to the parent can be undertaken concurrently with assessment and initial interventions. Question 2. System analysis indicates that a 5-year-old child presents to the emergency department with audible wheezing, increased work of breathing, and a history of recurrent respiratory symptoms. The child appears anxious and is speaking in short sentences. Based on current pediatric emergency nursing guidelines, which of the following initial management strategies is most appropriate? Option A. Administer a short-acting beta agonist SABA via nebulizer and reassess the child's respiratory status within 20 minutes. Option B. Obtain a portable chest X-ray to rule out pneumonia before initiating any bronchodilator therapy. Option C. Administer a SABA via meter-dose inhaler MDI with a spacer and monitor for improvement. Option D. Initiate intravenous corticosteroids and monitor vital signs closely. The correct answer is A. Administer a short-acting beta agonist SABA via nebulizer and reassess the child's respiratory status within 20 minutes. Explanation. Scenario analysis. Managing a pediatric asthma exacerbation presents a significant challenge due to the rapid and unpredictable nature of respiratory distress in children. Factors such as varying degrees of airway obstruction, potential for rapid decompensation, and the need for precise medication titration require constant vigilance and a systematic approach. The nurse must balance immediate symptom relief with ongoing assessment to prevent adverse outcomes and ensure adherence to established treatment protocols. Correct approach analysis. The correct approach, which involves administering a short-acting beta agonist, SABA, via nebulizer and assessing the child's response, aligns with current evidence-based guidelines for pediatric asthma exacerbation management. This approach prioritizes immediate bronchodilation to relieve bronchospasm, a primary driver of respiratory distress. The subsequent assessment allows for evaluation of treatment efficacy and guides further therapeutic decisions, such as the addition of systemic corticosteroids or escalation of care. This systematic, evidence-based approach is ethically mandated to provide the highest standard of care and is consistent with professional nursing standards of practice, which emphasize patient safety and optimal outcomes. Incorrect approaches analysis. Administering only a bronchodilator without assessing the response or considering adjunctive therapies like corticosteroids is insufficient. This approach fails to address the underlying inflammation, which is a critical component of asthma exacerbations and may lead to prolonged or recurrent symptoms. It represents a failure to adhere to comprehensive management protocols and could be considered a deviation from best practice, potentially impacting patient recovery. Delaying bronchodilator administration to first obtain a chest X-ray is inappropriate in an acute asthma exacerbation, unless there is a strong suspicion of a complication like pneumonia or pneumothorax. This delay can worsen hypoxia and respiratory distress, as bronchodilators are the first-line treatment for bronchospasm. This approach prioritizes diagnostic imaging over immediate therapeutic intervention, which is contrary to emergency management principles and could lead to adverse patient outcomes. Administering a SABA via meter-dose inhaler, MDI, with a spacer without first attempting nebulizer therapy, especially in a child experiencing moderate to severe distress, may be less effective. While MDIs can be effective, nebulizers often provide a more consistent and higher dose of medication, which is crucial in acute exacerbations. This approach might not deliver the optimal therapeutic dose required for rapid symptom relief in a distressed child, potentially delaying recovery and increasing the risk of deterioration. Professional reasoning. Professionals should employ a structured approach to pediatric asthma exacerbation management, beginning with rapid assessment of airway, breathing, and circulation. This should be followed by prompt administration of appropriate pharmacologic interventions, prioritizing bronchodilators. Continuous reassessment of the patient's response to treatment is paramount, guiding subsequent therapeutic decisions and the potential escalation of care. Adherence to evidence-based guidelines and institutional protocols ensures consistent, safe, and effective patient care. Question 3. Compliance review shows a 3-year-old child presenting to the pediatric emergency department with a fractured femur. The child is crying intermittently, pulling at their leg, and appears restless. The parents are visibly distressed and state, "He's in so much pain, but he can't tell us exactly where it hurts." As the certified pediatric emergency nurse, what is the most appropriate initial approach to assess and manage this child's pain? Option A. Utilize the Flack pain scale to objectively assess the child's pain level, incorporating parental observations of the child's behavior and comfort, and then administer prescribed analgesia based on the assessment findings. Option B. Wait for the child to stop crying and become quiet before attempting to assess their pain, as this indicates they are more receptive to questions. Option C. Rely solely on the parent's verbal report of "so much pain" to determine the appropriate analgesic dosage without further objective assessment. Option D. Administer a standard dose of acetaminophen based on the child's age, as this is a common and safe analgesic for pediatric pain. Correct answer is A. Utilize the FLAC pain scale to objectively assess the child's pain level, incorporating parental observations of the child's behavior and comfort, and then administer prescribed analgesia based on the assessment findings. Explanation. The scenario presents a common challenge in pediatric emergency nursing, assessing and managing pain in a nonverbal or preverbal child. This is professionally challenging because the nurse must rely on indirect indicators of pain, interpret subtle behavioral cues, and select appropriate interventions without direct verbal feedback from the patient. The nurse's judgment is critical in differentiating between pain, discomfort, fear, and other distress signals, ensuring that the child receives adequate pain relief while avoiding oversedation or adverse effects. The correct approach represents best professional practice because it aligns with established pediatric pain management guidelines and ethical principles. Utilizing a validated age-appropriate pain assessment tool, such as the FLAC, face, legs, activity, cry, consolability scale for infants and young children, allows for systematic and objective evaluation of pain. Incorporating parental input is crucial as parents are often the most knowledgeable about their child's baseline behavior and can provide valuable insights into subtle changes indicative of pain. This multimodal approach ensures a comprehensive assessment, leading to more accurate pain identification and targeted management strategies, thereby upholding the child's right to comfort and minimizing suffering, which is a core ethical and professional responsibility. An incorrect approach of solely relying on parental report without objective assessment is professionally unacceptable because it may lead to undertreatment or overtreatment of pain. While parental input is vital, it can be influenced by anxiety or prior experiences, and objective assessment provides a necessary layer of validation. This failure to employ a systematic assessment tool could violate nursing standards of care and potentially breach ethical obligations to provide evidence-based, individualized care. Another incorrect approach of administering a standard analgesic dose based on age alone, without a thorough pain assessment, is also professionally unacceptable. This disregards the principle of individualized care and the variability in pain perception and response among children. It risks inadequate pain relief or adverse drug reactions, contravening regulatory requirements for safe medication administration and ethical duties to prevent harm. A third incorrect approach of delaying pain management until the child can verbally express their pain is ethically and professionally indefensible. Pediatric emergency nursing mandates proactive pain management, especially for nonverbal children, where delayed intervention can lead to prolonged suffering, increased physiological stress, and potential long-term negative impacts. This failure to act promptly violates the fundamental ethical duty to alleviate suffering and the professional standard of care for pediatric pain management. The professional decision-making process for similar situations should involve a systematic approach. 1. Recognize the potential for pain. 2. Select and utilize an appropriate, validated pain assessment tool based on the child's developmental stage. 3. Actively involve parents or caregivers in the assessment process. 4. Interpret assessment findings in conjunction with clinical observations and the child's overall condition. 5. Develop and implement a pain management plan that may include pharmacological and non-pharmacological interventions. 6. Continuously reassess the child's pain and the effectiveness of interventions, adjusting the plan as needed. This iterative process ensures that pain management is dynamic, responsive, and aligned with best practices and regulatory expectations. Question 4. Assessment of a 3-year-old child presenting to the Pediatric Emergency Department with a 24-hour history of vomiting and diarrhea, characterized by decreased urine output and dry mucous membranes, requires a systematic approach to determine the most appropriate rehydration strategy. Considering the regulatory framework for pediatric emergency nursing, which of the following approaches best reflects evidence-based practice and patient safety? Option A. Administer an antiemetic and antidiarrheal medication to control symptoms before assessing the child's hydration status. Option B. Rely solely on the parent's report of the child's fluid intake and output to estimate the degree of dehydration and guide treatment decisions. Option C. Immediately administer intravenous fluids at a rapid rate to quickly correct any fluid deficit, given the history of vomiting and diarrhea. Option D. Initiate oral rehydration therapy with a commercially available electrolyte solution, closely monitoring for tolerance and signs of improvement, and escalating to intravenous fluids only if oral intake is not tolerated or dehydration worsens. The correct answer is D. Initiate oral rehydration therapy with a commercially available electrolyte solution, closely monitoring for tolerance and signs of improvement, and escalating to intravenous fluids only if oral intake is not tolerated or dehydration worsens. Explanation. Scenario analysis. Assessing a pediatric patient with gastroenteritis presents a significant challenge due to the rapid progression of dehydration, difficulty in accurately gauging fluid loss in young children, and the potential for underlying serious conditions mimicking simple gastroenteritis. The nurse must balance the need for prompt intervention with avoiding unnecessary or potentially harmful treatments. This requires a nuanced understanding of clinical signs and symptoms, age-specific considerations, and adherence to established rehydration protocols. Correct approach analysis. The correct approach prioritizes a comprehensive assessment of hydration status using validated clinical indicators, and then tailoring rehydration strategies based on the severity of dehydration and the child's tolerance. This aligns with best professional practice by ensuring patient safety, optimizing treatment efficacy, and adhering to evidence-based guidelines for pediatric emergency care. Specifically, it reflects the principles of the American Academy of Pediatrics, OP, Guidelines on Fluid and Electrolyte Management in Children, which emphasize a stepwise approach to rehydration, starting with oral rehydration therapy (ORT) for mild to moderate dehydration and progressing to intravenous Roman IV fluids for severe dehydration, or when ORT is not tolerated. This approach minimizes unnecessary interventions and focuses on the most effective and least invasive methods first, thereby reducing patient discomfort and healthcare costs. Incorrect approaches analysis. One incorrect approach involves immediately initiating intravenous fluid resuscitation for any child presenting with vomiting and diarrhea, regardless of their hydration status. This fails to adhere to established guidelines that advocate for ORT as the first-line treatment for mild to moderate dehydration. Ethically, this represents an overintervention, potentially exposing the child to the risks associated with Roman IV access, pain, infection, fluid overload, without clear medical necessity. It also deviates from the principle of using the least restrictive intervention necessary. Another incorrect approach is to solely rely on parental reports of fluid intake and output without performing a thorough clinical assessment of the child's hydration status. While parental input is valuable, it is not a substitute for objective clinical evaluation. This approach risks underestimating or overestimating the severity of dehydration, leading to either delayed or excessive treatment. Regulatory failure here lies in not adhering to the standard of care that mandates a comprehensive nursing assessment, which includes physical examination and observation of clinical signs. A third incorrect approach is to administer antiemetics or antidiarrheals without first addressing the primary issue of dehydration and assessing the underlying cause. While these medications may have a role in managing symptoms, they are not the primary treatment for gastroenteritis-induced dehydration and can mask the progression of the illness or have adverse effects in dehydrated children. This approach neglects the core principle of stabilizing the patient's physiological status before symptom management, which is a fundamental ethical and regulatory expectation in emergency nursing. Professional reasoning. Professionals should employ a systematic decision-making process that begins with a rapid but thorough assessment of the child's airway, breathing, and circulation, ABCs, followed by a detailed evaluation of hydration status. This involves assessing skin turgor, capillary refill time, mucous membrane moisture, urine output, and mental status. Based on these findings, the nurse should then consult established protocols and guidelines e.g. OP, Emergency Nurses Association, to determine the appropriate rehydration strategy, prioritizing ORT when feasible and progressing to Roman IV fluids only when indicated. Continuous reassessment of the child's response to treatment is crucial to adjust the plan of care as needed. This systematic, evidence-based approach ensures optimal patient outcomes and adherence to professional standards. Question 5. Comparative studies suggest that in the immediate post-resuscitation period for a pediatric patient who has experienced cardiac arrest, a nurse's approach to care significantly influences outcomes. Considering the critical need for vigilant management and the potential for rapid decompensation, which of the following nursing approaches best aligns with current pediatric emergency care guidelines and ethical imperatives? Option A. Rely on the physician's initial assessment and orders, intervening only when explicitly directed, to avoid overstepping professional boundaries and ensure a coordinated team approach. Option B. Implement continuous physiological monitoring, including cardiac rhythm, blood pressure, oxygen saturation, and end-tidal CO2, while initiating targeted temperature management as per protocol and proactively managing potential complications such as seizures and hypoglycemia. Option C. Discontinue advanced hemodynamic monitoring once the patient is hemodynamically stable for a brief period, as prolonged monitoring may be unnecessary and can be resource-intensive. Option D. Focus primarily on providing comfort measures and ensuring adequate pain control, as the patient has just undergone a traumatic event and may be sensitive to overstimulation. The correct answer is B. Implement continuous physiological monitoring, including cardiac rhythm, blood pressure, oxygen saturation, and end-tidal CO2, while initiating targeted temperature management as per protocol and proactively managing potential complications such as seizures and hypoglycemia. Explanation: this scenario is professionally challenging due to the critical nature of post-resuscitation care in pediatric emergencies, where subtle changes can have profound impacts on patient outcomes. The nurse must balance immediate interventions with ongoing assessment and anticipate potential complications, all while adhering to established protocols and evidence-based guidelines. Careful judgment is required to interpret complex physiological data and make timely, informed decisions. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based assessment and management strategy aligned with current pediatric resuscitation guidelines. This includes continuous physiological monitoring, targeted temperature management, TTM if indicated, and proactive management of potential complications such as hypoglycemia, seizures, and hemodynamic instability. Adherence to these guidelines, often codified in institutional policies and professional standards of care, e.g., American Heart Association Guidelines for Pediatric Advanced Life Support, ensures a consistent and high-quality standard of care, minimizing the risk of adverse events and optimizing recovery. Ethical considerations of beneficence and non-maleficence are directly addressed by this approach, aiming to do the most good and avoid harm. An incorrect approach that focuses solely on comfort measures without comprehensive physiological monitoring fails to meet the standard of care. This could lead to undetected deterioration, such as worsening hypoxia or evolving neurological compromise, directly violating the principle of non-maleficence. Furthermore, it may contravene regulatory requirements for diligent patient assessment and intervention in critical care settings. Another incorrect approach that involves prematurely discontinuing advanced monitoring without clear clinical improvement or a defined endpoint for observation neglects the potential for delayed complications. This could be seen as a deviation from best practice and potentially violate institutional policies or professional standards that mandate a period of close observation post-resuscitation. The ethical principle of beneficence is compromised by not providing the necessary level of care to ensure optimal recovery. A third incorrect approach that relies on anecdotal experience or intuition rather than established protocols and evidence-based guidelines is professionally unacceptable. This introduces variability and subjectivity into critical care, increasing the risk of error and inconsistent outcomes. It may also fall short of regulatory expectations for evidence-based practice and could be considered a breach of professional duty. The professional decision-making process for similar situations should involve a rapid, systematic assessment using a structured framework, e.g., UPDE approach, continuous reevaluation of the patient's status, consultation with the interdisciplinary team, and strict adherence to evidence-based guidelines and institutional protocols. This ensures that care is patient-centered, safe, and effective, promoting the best possible outcomes for the pediatric patient. Question 6. Risk assessment procedures indicate a 4-year-old child presents to the pediatric emergency department with sudden onset of hives, lip swelling, and wheezing shortly after consuming a known allergen. The child appears anxious, is breathing rapidly, and has a heart rate of 140 beats per minute. The nurse recognizes the potential for rapid deterioration. Which of the following immediate actions is most critical for the certified pediatric emergency nurse to implement? Option A. Initiate intravenous fluid bolus and administer supplemental oxygen. Option B. Contact the attending physician for immediate consultation before any intervention. Option C. Administer intravenous antihistamines and corticosteroids. Option D. Administer intramuscular epinephrine. Correct answer is D. Administer intramuscular epinephrine. Explanation. Scenario analysis. This scenario presents a common yet critical pediatric emergency where rapid and accurate assessment of anaphylaxis is paramount. The challenge lies in differentiating anaphylaxis from other conditions that may present with similar symptoms, such as asthma exacerbations or vasovagal reactions, especially in a young child where communication is limited. The potential for rapid deterioration necessitates immediate, evidence-based intervention while simultaneously gathering further information. Correct approach analysis. The correct approach prioritizes immediate administration of epinephrine, the first-line treatment for anaphylaxis, as per established pediatric emergency nursing guidelines and protocols. This aligns with the principle of do no harm by addressing the life-threatening airway compromise and cardiovascular collapse associated with anaphylaxis. Delaying epinephrine while seeking definitive confirmation or alternative diagnosis could lead to irreversible harm or death. This approach is supported by regulatory frameworks that mandate adherence to evidence-based emergency protocols and the nurse's professional responsibility to act decisively in life-threatening situations. Incorrect approach is analysis. Administering only antihistamines and corticosteroids without epinephrine fails to address the immediate life-threatening airway and cardiovascular components of anaphylaxis. While these medications may play a role in managing later-stage symptoms, they are not first-line treatments for acute anaphylactic shock and represent a significant deviation from established protocols, potentially leading to severe patient harm. This constitutes a failure to adhere to accepted standards of care and could be considered professional negligence. Initiating intravenous fluids and oxygen without epinephrine, while supportive measures, are insufficient as primary treatment for anaphylaxis. Anaphylaxis is a systemic hypersensitivity reaction that requires immediate reversal of bronchoconstriction and vasoconstriction, which only epinephrine can effectively provide. Relying solely on supportive care delays critical intervention and risks progression of the anaphylactic cascade, violating the duty to provide appropriate and timely treatment. Seeking immediate physician consultation before administering any medication, while generally good practice for complex cases, is inappropriate in a clear anaphylaxis presentation. The urgency of anaphylaxis dictates that the nurse must initiate life-saving treatment, epinephrine, without delay. While communication with the physician is important for ongoing management, it should not supersede the immediate administration of epinephrine when indicated by the clinical presentation, as per emergency nursing protocols. This delay in administering a critical intervention could be viewed as a failure to act within the scope of practice and established emergency protocols. Professional reasoning. In managing suspected anaphylaxis in a pediatric patient, the professional decision-making process should follow a structured approach. 1. Rapidly assess for signs and symptoms indicative of anaphylaxis, e.g., urticaria, angioedema, bronchospasm, hypotension, gastrointestinal distress. 2. Immediately administer intramuscular epinephrine if anaphylaxis is strongly suspected, based on clinical presentation and established protocols. 3. Simultaneously, initiate supportive measures such as oxygen and intravenous fluids. 4. Secure intravenous access for further medication administration and fluid resuscitation. 5. Notify the physician promptly to report the situation and the interventions initiated. 6. Continuously monitor the patient's vital signs and response to treatment, and be prepared to administer further doses of epinephrine or other medications as needed. 7. Document all assessments, interventions, and patient responses meticulously. This systematic approach ensures that the most critical, life-saving intervention is delivered without delay, while also addressing other necessary aspects of patient care and communication. Question 7. To address the challenge of optimizing the use of an automated external defibrillator (ED) in a pediatric emergency, Which of the following actions best reflects current pediatric resuscitation guidelines and regulatory expectations for emergency care providers? Option A. Apply adult AED pads to the child's chest in the standard adult anterior lateral placement, regardless of the child's size, and proceed with defibrillation if indicated by the AED. Option B. Immediately apply adult AED pads to the child's chest, ensuring good contact, and proceed with defibrillation if indicated by the AED. Option C. If pediatric AED pads are not immediately available, use adult pads but ensure they do not touch each other by placing one on the anterior chest and the other on the posterior back, and proceed with defibrillation if indicated. Option D. Prioritize locating pediatric-specific AED pads, even if it delays the initiation of defibrillation or CPR, to ensure the most appropriate energy delivery. The correct answer is B. Immediately apply adult AED pads to the child's chest, ensuring good contact, and proceed with defibrillation if indicated by the AED. Explanation: the scenario of using an automated external defibrillator (ED) on a pediatric patient presents a significant professional challenge due to the critical nature of the situation, the potential for irreversible harm, and the need for rapid, precise decision-making under extreme stress. Pediatric patients have different physiological responses and anatomical considerations compared to adults, requiring specialized knowledge and adherence to specific protocols to ensure patient safety and optimize outcomes. The correct approach must align with established pediatric resuscitation guidelines and regulatory frameworks governing emergency care. The correct approach represents best professional practice because it prioritizes patient safety and adherence to evidence-based guidelines. Specifically, it involves utilizing pediatric-specific AED pads and, if unavailable, correctly attenuating adult pads to deliver appropriate energy levels, as recommended by organizations like the American Heart Association, AHA, and supported by regulatory bodies overseeing emergency medical services. This ensures that the electrical shock delivered is tailored to the child's size and physiology, minimizing the risk of myocardial damage or ineffective resuscitation. Furthermore, it emphasizes continuous high-quality cardiopulmonary resuscitation, CPR, before and after AED application, which is crucial for maintaining blood flow and oxygenation to vital organs. An incorrect approach, such as using adult pads without attenuation on a young child, represents a significant regulatory and ethical failure. This could lead to overdosing the patient with electrical energy, causing iatrogenic injury or ineffective defibrillation, directly violating the principle of do no harm, non-maleficence. Another incorrect approach, such as delaying CPR to search for pediatric pads when adult pads are available and can be attenuated, is also ethically and regulatorily problematic. It demonstrates a failure to act decisively in a life-threatening emergency, potentially leading to a worse outcome for the patient and violating the duty to provide timely and appropriate care. Failing to follow established pediatric resuscitation algorithms, which are often mandated by state or national emergency medical services regulations, constitutes a breach of professional standards and potentially legal liability. Professional decision-making in such situations requires a systematic approach. This includes rapid assessment of the patient's condition, immediate initiation of high-quality CPR, and prompt application of the AED according to established protocols. The decision-making process should involve recalling and applying specific pediatric resuscitation guidelines, understanding the limitations and appropriate use of available equipment, including adult VS, pediatric pads, and prioritizing actions that offer the greatest potential benefit with the least harm. Continuous training and competency validation in pediatric resuscitation are essential for maintaining the skills and knowledge necessary to navigate these challenging scenarios effectively and ethically. Question 8. Quality control measures reveal a 3-year-old child presenting to the pediatric emergency department with increased work of breathing, audible wheezing, and mild intercostal retractions. The parents report the child has had a cough for 2 days and has been more irritable than usual. The nurse is initiating the initial assessment. Which of the following approaches best reflects a risk assessment strategy for this child's respiratory status? Option A. Wait for the child to become overtly cyanotic or apneic before notifying the physician, as this indicates a clear need for intervention. Option B. Focus on gathering detailed historical information from the parents about the onset and progression of symptoms before performing a physical assessment. Option C. Conduct a rapid, systematic physical assessment, including observation of respiratory effort, auscultation of breath sounds, assessment of oxygen saturation, and evaluation of mental status to determine the degree of respiratory distress and risk of failure. Option D. Immediately administer high-flow oxygen and nebulized albuterol, then reassess after 15 minutes. The correct answer is D. Immediately administer high-flow oxygen and nebulized albuterol, then reassess after 15 minutes. Explanation: this scenario presents a professionally challenging situation due to the rapid deterioration of a pediatric patient's respiratory status, demanding immediate and accurate risk assessment to guide appropriate intervention. The challenge lies in distinguishing between compensated respiratory distress and impending respiratory failure, where subtle clinical cues can signify a critical shift. Failure to accurately assess risk can lead to delayed or inappropriate treatment, with potentially life-threatening consequences for a child. The correct approach represents best professional practice by prioritizing a systematic and evidence-based assessment of the child's respiratory effort, oxygenation, and perfusion. This aligns with established pediatric emergency nursing guidelines, such as those promoted by the Emergency Nurses Association (ENA) and the American Academy of Pediatrics (OP), which emphasize a head-to-toe assessment and the use of validated pediatric assessment tools. Specifically, focusing on objective signs like retractions, grunting, nasal flaring, cyanosis, altered mental status, and tachypnea, while also considering subjective cues like parental concern, allows for a comprehensive understanding of the child's physiological state. This approach ensures that interventions are tailored to the severity of the distress and the likelihood of progression to failure, thereby optimizing patient outcomes and adhering to the standard of care. An incorrect approach that relies solely on subjective parental reports without objective assessment fails to meet the standard of care. This is a regulatory and ethical failure because it neglects the nurse's primary responsibility to conduct a thorough clinical evaluation. It also risks misinterpreting the severity of the situation, potentially delaying critical interventions. Another incorrect approach, focusing only on administering oxygen without a comprehensive assessment of the underlying cause and the child's overall respiratory mechanics, is also professionally unacceptable. While oxygen is a vital intervention, its administration without understanding the full clinical picture can mask worsening hypoxia or fail to address other critical issues contributing to respiratory distress. This can lead to a false sense of security and delay more definitive treatments. Furthermore, an approach that delays escalation of care to a physician or advanced practitioner until the child is overtly in failure is a significant ethical and regulatory breach. Pediatric emergency nursing standards mandate timely consultation and collaboration when a patient's condition is unstable or deteriorating, ensuring that the most appropriate level of expertise is involved in management. Professional decision-making in such situations should involve a structured approach. First, recognize the potential for respiratory compromise. Second, conduct a rapid, systematic assessment of airway, breathing, and circulation, noting both objective and subjective findings. Third, interpret these findings in the context of the child's age and underlying condition to determine the level of risk for respiratory failure. Fourth, implement immediate interventions based on the assessed risk, such as positioning, oxygen therapy, or bronchodilators. And fifth, continuously reassess the child's response and escalate care as needed, communicating effectively with the healthcare team. Question 9. Risk assessment procedures indicate a 6-month-old infant is in severe respiratory distress, requiring immediate intubation and mechanical ventilation. The parents, who are Jehovah's Witnesses, have expressed a strong religious objection to any blood transfusions, which the medical team anticipates may be necessary due to the infant's condition and potential for bleeding during the procedure. The nurse is aware of the potential need for blood products, but also the parents' deeply held beliefs. What is the most appropriate immediate nursing action? Option A. Proceed with intubation and resuscitation, informing the parents that blood transfusions will be administered if deemed medically necessary, regardless of their objections. Option B. Initiate resuscitation and intubation as per protocol, while immediately initiating a discussion with the parents about the potential need for blood products and exploring alternatives with the medical team. Option C. Respect the parent's wishes and withhold intubation and ventilation, explaining that the medical team cannot proceed against their religious beliefs. Option D. Halt all resuscitation efforts until a legal guardian can be appointed who will consent to all necessary medical interventions. The correct answer is B. Initiate resuscitation and intubation as per protocol, while immediately initiating a discussion with the parents about the potential need for blood products and exploring alternatives with the medical team. Explanation. This scenario presents a profound ethical dilemma common in pediatric emergency nursing, specifically concerning the resuscitation of a critically ill infant where parental wishes conflict with perceived best medical practice. The challenge lies in balancing the nurse's professional obligation to provide life-saving care with the parent's right to make decisions for their child, even when those decisions may lead to adverse outcomes. Navigating this requires a deep understanding of ethical principles, legal frameworks governing pediatric care, and effective communication strategies. The correct approach emphasizes shared decision-making, open communication, and seeking ethical consultation. This aligns with best professional practice by prioritizing the child's well-being while respecting parental autonomy within legal and ethical boundaries. It involves a collaborative effort to understand the parent's concerns, provide clear and compassionate explanations of the medical situation and proposed interventions, and explore all available options. This approach is supported by ethical guidelines that advocate for patient-centered care and the principle of beneficence, ensuring that the child's best interests are paramount. Legally, it upholds the importance of informed consent and the right of parents to participate in their child's medical care, while also recognizing the nurse's duty to advocate for the child. An incorrect approach that disregards parental wishes and proceeds with resuscitation without further dialogue or consultation would be professionally unacceptable. This would violate the ethical principle of respect for autonomy, as it overrides the parent's right to make decisions for their child. It could also lead to legal challenges related to battery or lack of informed consent. Another incorrect approach, such as abandoning the resuscitation attempt solely based on parental objection without exploring alternatives or seeking further guidance, would fail the ethical duty of non-maleficence and beneficence, potentially leading to the child's death when interventions might have been beneficial. This also neglects the nurse's professional responsibility to advocate for the child and to ensure all avenues for care are explored. Professionals should employ a structured decision-making process that begins with a thorough assessment of the clinical situation and the parent's understanding and concerns. This should be followed by open, empathetic communication, seeking to build trust and a shared understanding. If a significant conflict persists, involving the healthcare team, including physicians and social work, is crucial. Ethical consultation services should be utilized to provide guidance and support in navigating complex ethical issues. Documenting all discussions, decisions, and consultations thoroughly is also a critical component of professional practice. Question 10. Benchmark analysis indicates that in a pediatric emergency scenario involving a suspected cardiac arrest, the immediate and most critical intervention for a certified pediatric emergency nurse to perform is to: Option A. Begin a detailed history taking from bystanders to understand the child's pre-arrest condition. Option B. Administer a specific intravenous medication based on a presumptive diagnosis of the arrest's cause. Option C. Initiate high-quality chest compressions at the correct rate and depth, ensuring minimal interruptions. Option D. Focus primarily on establishing an advanced airway before commencing any resuscitation efforts. The correct answer is C. Initiate high-quality chest compressions at the correct rate and depth, ensuring minimal interruptions. Explanation. This scenario presents a professionally challenging situation due to the critical nature of pediatric emergency care and the immediate need for effective basic life support, BLS, interventions. The nurse must rapidly assess the child's condition and initiate appropriate BLS according to established pediatric emergency guidelines, which are paramount for patient survival and minimizing long-term sequelae. The challenge lies in the swift and accurate application of these protocols under pressure, ensuring the highest standard of care is delivered without delay. The correct approach represents best professional practice because it aligns directly with the current American Heart Association guidelines for cardiopulmonary resuscitation and emergency cardiovascular care, which are the regulatory framework for BLS in the United States for this certification. These guidelines emphasize prompt recognition of cardiac arrest, immediate high-quality chest compressions, and timely defibrillation if indicated. Adhering to these evidence-based protocols ensures the most effective intervention for pediatric cardiac arrest, maximizing the chance of return of spontaneous circulation and survival. This approach is ethically mandated by the nurse's professional responsibility to provide competent and evidence-based care. An incorrect approach that involves delaying chest compressions to administer a specific medication without confirming airway patency or the need for that medication would be a significant regulatory and ethical failure. The AHA guidelines prioritize chest compressions and ventilation over medication administration in the initial stages of pediatric arrest, unless a specific reversible cause is immediately apparent and treatable with that medication. Delaying compressions directly violates the core principles of BLS, which are designed to maintain vital organ perfusion. Furthermore, administering medication without proper assessment and indication could lead to adverse effects and is a deviation from the standard of care, potentially constituting negligence. Another incorrect approach, such as focusing solely on ventilation without adequate chest compressions, would also be a critical failure. While ventilation is crucial, effective chest compressions are essential for circulating oxygenated blood to the brain and vital organs during pediatric arrest. Inadequate compressions mean that even with good ventilation, the child's brain will not receive the necessary oxygen, severely limiting the chances of a positive outcome. This failure to provide comprehensive BLS as per the guidelines is a breach of professional duty. A third incorrect approach, such as waiting for advanced airway placement before initiating chest compressions, is also unacceptable. Current pediatric BLS guidelines advocate for starting chest compressions immediately upon recognizing cardiac arrest, even before an advanced airway is secured. The delay associated with advanced airway placement can lead to prolonged interruptions in chest compressions, which is detrimental to the patient's outcome. The professional decision-making process for similar situations should involve a systematic approach guided by the established BLS algorithms. This includes rapid scene assessment, recognition of unresponsiveness and absent or abnormal breathing, immediate activation of the emergency response system, and prompt initiation of high-quality chest compression. Continuous assessment of the child's response to interventions and adherence to the step-by-step protocols are crucial. Nurses should rely on their training, the current guidelines, and critical thinking skills to prioritize interventions that have the greatest impact on patient survival. Regular skills validation and continuing education are vital to maintain proficiency in these life-saving techniques. Question 11. Consider a scenario where a 3-year-old child presents to the emergency department with a high fever and inconsolable crying. The nurse observes the child clinging tightly to their parent, exhibiting rapid breathing and avoiding eye contact. Which approach best reflects an understanding of developmental stages in assessing and managing this pediatric emergency? Option A. Attempt to distract the child with toys and bright lights to calm them before proceeding with any assessment, believing that a calm child will provide more accurate physical findings. Option B. Assess the child using the same pain and distress scales typically used for adults, assuming that the underlying physiological responses are similar regardless of age. Option C. Prioritize immediate administration of antipyretics and intravenous fluids based on vital signs alone, assuming the crying is solely due to fever. Option D. Focus on obtaining a detailed medical history from the parents while observing the child's physical signs, recognizing that a 3-year-old's crying and clinging are typical responses to illness and fear, and may mask or amplify other symptoms. The correct answer is C. Prioritize immediate administration of antipyretics and intravenous fluids based on vital signs alone, assuming the crying is solely due to fever. Explanation. This scenario presents a professional challenge due to the critical need to accurately assess and respond to a pediatric patient's distress, which is heavily influenced by their developmental stage. Misinterpreting a child's behavior based on age can lead to delayed or inappropriate interventions, potentially impacting patient outcomes and violating standards of care. The nurse must integrate knowledge of developmental psychology with emergency nursing principles. The correct approach represents best professional practice because it prioritizes a comprehensive assessment that considers the child's developmental stage as a primary lens for interpreting their behavior and needs. This aligns with the ethical principle of beneficence, ensuring the child receives care tailored to their unique developmental capacity for understanding, communication, and coping. Regulatory frameworks for pediatric emergency nursing emphasize patient-centered care, which inherently includes acknowledging and adapting to developmental differences. This approach promotes effective communication, reduces anxiety, and facilitates accurate diagnosis and treatment by understanding what is age-appropriate behavior versus a sign of significant distress. An incorrect approach that focuses solely on the physical presentation without considering developmental context is professionally unacceptable. This fails to meet the standard of care for pediatric patients, potentially leading to misdiagnosis or underestimation of the child's condition. Ethically, it violates the principle of non-maleficence by risking harm through inadequate care. Regulatory failure would stem from not adhering to established pediatric emergency nursing protocols that mandate developmental considerations. Another incorrect approach that relies on parental interpretation alone, without independent nursing assessment, is also professionally flawed. Parental input is valuable. The nurse has the specialized knowledge and responsibility to assess the child directly. Over-reliance on parents can lead to overlooking subtle but critical signs of illness or injury that parents might not recognize or articulate. This abdication of professional responsibility can be seen as a regulatory and ethical breach, as the nurse is failing to exercise their independent clinical judgment. A third incorrect approach that applies adult assessment techniques to a pediatric patient is fundamentally inappropriate. Children are not small adults. Their physiological and psychological responses to illness and injury differ significantly. Applying adult frameworks can lead to misinterpretation of vital signs, pain assessment, and behavioral cues, resulting in potentially dangerous treatment errors. This directly contravenes pediatric-specific nursing standards and regulatory guidelines designed to protect this vulnerable population. The professional decision-making process for similar situations should involve a systematic approach. First, gather subjective data, parental report, child's verbalizations if able. Second, perform objective assessment, always filtering observations through the lens of the child's developmental stage. Third, integrate findings to form a differential diagnosis and plan of care. And fourth, continuously reassess and adapt the plan based on the child's response and evolving condition, always prioritizing the child's safety and well-being within the established regulatory and ethical framework. Question 12. The investigation demonstrates a pediatric patient presenting to the emergency department with significant blunt force trauma following a motor vehicle accident. The nurse is tasked with initiating the initial assessment and management. Which of the following approaches best reflects the standard of care for a certified pediatric emergency nurse in this situation? Option A. Prioritize comforting the distressed parents and gathering their detailed history of the event before beginning any physical assessment of the child. Option B. Immediately initiate a systematic head-to-toe secondary survey, ensuring all body systems are assessed after the primary survey is complete. Option C. Delegate the initial comprehensive physical assessment to the resident physician to ensure the most experienced medical perspective is applied first. Option D. Conduct a rapid, focused assessment of the most apparent injury, then await physician evaluation before proceeding with a more detailed examination. The correct answer is D. Conduct a rapid, focused assessment of the most apparent injury, then await physician evaluation before proceeding with a more detailed examination. Explanation. Scenario analysis. This scenario is professionally challenging due to the inherent instability of a pediatric trauma patient and the critical need for rapid, accurate assessment and intervention. The nurse must balance the urgency of the situation with the meticulous application of established protocols, while also considering the unique physiological differences in children compared to adults. Effective communication with the trauma team and the family, if present, is paramount. Correct approach analysis. The correct approach prioritizes a systematic head-to-toe assessment following established pediatric trauma guidelines, such as those outlined by the American Academy of Pediatrics and the Emergency Nurses Association, ENA. This ensures that all potential injuries are identified and addressed in a logical sequence, minimizing the risk of overlooking critical findings. Adherence to these guidelines is mandated by professional nursing standards and is essential for providing safe and effective care, aligning with the nurse's legal and ethical obligations to the patient. Incorrect approach is analysis, an approach that focuses solely on the most obvious injury without a comprehensive secondary survey fails to meet the standard of care. This could lead to missed internal injuries or other life-threatening conditions, violating the nurse's duty to provide thorough assessment and care. This oversight could be considered a breach of professional negligence, prioritizing family comfort over immediate medical assessment, while compassionate, is a regulatory and ethical failure in an acute trauma situation. Primary responsibility of the emergency nurse is to stabilize and treat the patient. While family presence can be beneficial, it should not impede or delay essential life-saving interventions. This could be viewed as a failure to uphold the patient's right to timely and appropriate medical care. Relying solely on the physician's initial assessment without conducting an independent, comprehensive nursing assessment is a deviation from best practice and potentially a regulatory violation. The nurse has a distinct role in patient assessment and monitoring, and independent judgment is expected. This could be interpreted as a failure to exercise professional autonomy and responsibility. Professional reasoning. Professionals should employ a structured decision-making process that begins with recognizing the critical nature of the situation. This involves activating the trauma team, initiating primary survey update, and then proceeding to a systematic secondary survey. Continuous reassessment and clear, concise communication with the interdisciplinary team are vital. Understanding and applying evidence-based pediatric trauma guidelines, as well as institutional protocols, forms the foundation of safe and effective practice. Ethical considerations, such as patient advocacy and informed consent, when applicable and possible, are integrated throughout the process. Question 13. Upon reviewing a 4-year-old child who is unresponsive and not breathing normally, what is the most appropriate initial cardiopulmonary resuscitation (CPR) technique to implement according to current pediatric emergency care guidelines? Option A. Begin chest compressions using the heel of one hand with a depth of at least 2 inches at a rate of 100-120 compressions per minute, and provide rescue breaths in a 15:2 ratio. Option B. Administer 2 rescue breaths immediately, followed by chest compressions at a rate of 80-100 compressions per minute with a depth of approximately 1.5 inches. Option C. Initiate chest compressions with a depth of approximately 1/3 the anterior-posterior diameter of the chest at a rate of 100-120 compressions per minute, and provide rescue breaths in a 30:2 ratio. Option D. Apply chest compressions using 2 hands with a depth of at least 2 inches at a rate of 100-120 compressions per minute, and provide rescue breaths in a 30:2 ratio. Correct answer is C. Initiate chest compressions with a depth of approximately 1/3 the anterior-posterior diameter of the chest at a rate of 100-120 compressions per minute, and provide rescue breaths in a 30:2 ratio. Explanation. This scenario presents a common yet critical challenge in pediatric emergency nursing, adapting established CPR techniques to the unique physiological needs of a child while adhering to current evidence-based guidelines. The professional challenge lies in the rapid assessment of the child's condition, accurate identification of the appropriate CPR approach, and the precise execution of interventions under pressure. The nurse must balance the urgency of the situation with the need for accurate technique to maximize the child's chance of survival and minimize potential harm. The correct approach represents best professional practice because it aligns with the American Heart Association (AHA) guidelines for cardiopulmonary resuscitation and emergency cardiovascular care, which are the prevailing standards in the United States for pediatric CPR. Specifically, the AHA guidelines emphasize the importance of appropriate compression depth and rate, adequate ventilation, and the consideration of the child's age and size when determining the technique. Adhering to these evidence-based guidelines ensures that the interventions are as effective as possible, maximizing oxygen delivery to vital organs and improving the likelihood of successful resuscitation. This approach is ethically sound, as it prioritizes the patient's well-being and adheres to the professional standard of care. An incorrect approach that involves using adult CPR techniques without modification is professionally unacceptable due to specific regulatory and ethical failures. The AHA guidelines clearly differentiate pediatric CPR from adult CPR, primarily due to anatomical and physiological differences. Using adult techniques such as excessive compression force or depth can lead to significant injury in a child, including rib fractures, pneumothorax, or internal organ damage, thereby violating the ethical principle of non-maleficence, do no harm. Furthermore, failing to adjust ventilation volume for a child's smaller lung capacity can result in barotrauma or gastric distension, compromising ventilation and potentially worsening the outcome. This failure to apply the correct pediatric-specific standard of care constitutes a breach of professional duty and regulatory compliance with established emergency care protocols. Another incorrect approach might involve delaying chest compressions to administer medications or perform other interventions before initiating CPR. This is a critical regulatory and ethical failure because the AHA guidelines unequivocally state that immediate chest compressions are paramount in pediatric resuscitation. Prolonged interruption of chest compressions significantly reduces coronary perfusion pressure and the chances of successful resuscitation. Delaying this life-saving intervention violates the ethical imperative to act swiftly and decisively in a life-threatening situation and fails to meet the established standard of care for pediatric emergency response. The professional decision-making process for similar situations should involve a rapid, systematic assessment of the pediatric patient. This includes evaluating responsiveness, breathing, and circulation. Based on this assessment, the nurse should immediately identify whether the situation warrants basic life support, BLS, or advanced cardiovascular life support, ACLS, interventions. For BLS, the decision-making process must prioritize the initiation of high-quality chest compressions at the correct rate and depth, followed by appropriate rescue breaths, always considering the child's age and size. If advanced interventions are indicated, the decision-making process involves recognizing the underlying cause of the arrest and initiating appropriate ACLS algorithms, which are also guided by AHA standards. Continuous reassessment and adaptation of the resuscitation strategy based on the patient's response are crucial components of effective pediatric emergency care. Question 14. The evaluation methodology shows that a certified pediatric emergency nurse is responsible for administering a critical medication to a pediatric patient. While the calculation of the correct dose is a vital step, what is the most crucial aspect of the risk assessment process to ensure patient safety in this scenario, beyond the initial numerical computation? Option A. Relying on the nurse's extensive experience and clinical judgment to estimate the appropriate dosage if the exact calculation is time-consuming in a rapidly evolving emergency. Option B. Delegating the final confirmation of the dosage to a more senior physician without direct nurse involvement in the verification loop. Option C. Administering the medication based on a visual approximation of the child's size and a general understanding of typical pediatric dosages for similar conditions. Option D. Implementing a multi-step verification process involving independent double-checking of the calculated dose by another qualified healthcare professional and cross-referencing with the patient's medical record and a current drug reference guide. The correct answer is D. Implementing a multi-step verification process involving independent double-checking of the calculated dose by another qualified healthcare professional and cross-referencing with the patient's medical record and a current drug reference guide. Explanation: this scenario is professionally challenging due to the critical nature of pediatric emergency care, where errors in medication administration can have severe and irreversible consequences. The nurse must balance rapid assessment, critical thinking, and precise adherence to safety protocols, especially when dealing with dosage calculations, even when the calculation itself is not the primary focus of the question. The inherent vulnerability of pediatric patients necessitates an unwavering commitment to patient safety and regulatory compliance. The correct approach represents best professional practice because it prioritizes a multi-layered safety check that aligns with established pediatric emergency nursing standards and regulatory guidelines. This includes independent verification of calculations, cross-referencing with reliable resources, and ensuring the medication is appropriate for the child's specific condition and weight. This systematic approach minimizes the risk of medication errors, a key tenet of patient safety regulations and ethical nursing practice. An incorrect approach that relies solely on the initial calculation without further verification fails to meet the standard of care and regulatory requirements for medication safety. This bypasses crucial safety checks designed to prevent errors, potentially leading to adverse drug events. Ethically, it demonstrates a lapse in due diligence and a failure to uphold the nurse's responsibility to protect the patient from harm. Another incorrect approach that involves administering medication based on a feeling or approximation, even if the child appears stable, is a direct violation of established protocols and regulatory mandates for precise medication administration. This disregards the scientific basis of pediatric dosing and introduces an unacceptable level of risk. It is ethically indefensible as it prioritizes subjective judgment over objective, evidence-based practice. A further incorrect approach that involves delegating the final dosage verification to an unlicensed individual or failing to involve a second licensed professional in the verification process when indicated by policy or complexity represents a significant regulatory and ethical failure. This undermines the principle of accountability and the importance of a robust safety net in medication administration. It is a failure to adhere to best practices for error prevention and patient safety. The professional reasoning process for similar situations should involve a systematic approach. First, accurately assess the patient's condition and the need for medication. Second, perform the dosage calculation using a reliable method and the correct formula. Third, independently verify the calculation, ideally with a second licensed professional or by cross-referencing with a trusted resource. Fourth, confirm the appropriateness of the medication and dose for the specific patient, considering weight, age, and clinical status. Finally, administer the medication with meticulous attention to detail and monitor the patient's response. This structured approach, grounded in regulatory requirements and ethical principles, ensures the highest level of patient safety. Question 15. Examination of the data shows an infant presenting with increased work of breathing, tachypnea, and mild retractions. The nurse is considering initial interventions. Which of the following approaches best reflects an understanding of the differences in pediatric anatomy and physiology that contribute to respiratory distress in this age group? Option A. Initiating positive pressure ventilation with a bag valve mask using adult-sized equipment to ensure adequate tidal volume. Option B. Administering a high concentration of supplemental oxygen via a non-rebreather mask, assuming the infant's metabolic demands are similar to an adult's. Option C. Administering a sedative to reduce the infant's respiratory rate and work of breathing, as a slower rate is generally indicative of improved respiratory status. Option D. Focusing on maintaining a patent airway by ensuring the infant is breathing through their nose, as infants are obligate nose breathers and nasal obstruction can significantly impair ventilation. The correct answer is B. Administering a high concentration of supplemental oxygen via a non-rebreather mask, assuming the infant's metabolic demands are similar to an adult's. Explanation. Scenario analysis. This scenario presents a common but critical challenge in pediatric emergency nursing, recognizing and responding to a respiratory distress presentation in an infant, where anatomical and physiological differences from adults significantly impact assessment and intervention. The challenge lies in the subtle, yet vital, distinctions in airway anatomy, lung compliance, and metabolic rate that can lead to rapid deterioration if not promptly and accurately addressed. Misinterpreting these differences can result in delayed or inappropriate treatment, with potentially severe consequences for the child. Correct approach analysis. The correct approach prioritizes intervention that directly address the underlying physiological differences in infants experiencing respiratory distress. This involves recognizing that infants have smaller airways, a higher respiratory rate, and are obligate nose breathers, making them more susceptible to obstruction. Their immature diaphragm and reliance on accessory muscles for breathing mean that fatigue can set in quickly. Furthermore, their higher metabolic rate and limited glycogen stores mean that hypoxia and hypoglycemia can develop rapidly. Therefore, interventions that support breathing, maintain oxygenation, and minimize metabolic demands are paramount. This aligns with best professional practice as outlined by pediatric emergency nursing guidelines, which emphasize a thorough understanding of pediatric-specific physiology to guide assessment and treatment, ensuring patient safety and optimal outcomes. Incorrect approaches analysis. An incorrect approach would involve applying adult-based assessment or treatment protocols without considering the unique pediatric anatomy and physiology. For instance, assuming a child can tolerate the same level of oxygen saturation as an adult, or using adult-sized airway adjuncts, would be a significant failure. Treating respiratory distress solely as a generic condition, without accounting for the infant's smaller lung volumes and higher respiratory drive, could lead to inadequate ventilation or excessive oxygen administration, both of which can be harmful. Failing to recognize the implications of an infant's obligate nasal breathing and the potential for nasal obstruction to cause significant distress is another critical oversight. These failures represent a deviation from evidence-based pediatric emergency care standards and could be considered a breach of professional duty of care. Professional reasoning. Professionals should approach pediatric respiratory distress by first recalling the fundamental differences in pediatric anatomy and physiology compared to adults. This includes airway size and structure, respiratory mechanics, metabolic rate, and thermoregulation. The assessment should then be tailored to these differences, looking for signs of distress that are specific to infants and children, e.g., grunting, nasal flaring, retractions, tachypnea. Interventions should be guided by these physiological considerations, aiming to support the child's immature systems while minimizing stress. Continuous reassessment is crucial, as pediatric patients can decompensate rapidly. Collaboration with the healthcare team and adherence to established pediatric emergency protocols are essential components of effective decision-making. Question 16. Performance analysis shows that nurses caring for infants presenting with signs of respiratory distress, such as tachypnea, retractions, and wheezing, often employ varying strategies. Considering a 6-month-old infant with moderate respiratory distress, a history of a recent upper respiratory infection, and an oxygen saturation of 92% on room air, which of the following approaches best reflects current pediatric emergency nursing best practices and regulatory guidelines? Option A. Rely primarily on the parent's description of the infant's symptoms and provide reassurance without a detailed physical examination, as bronchiolitis is typically self-limiting. Option B. Immediately administer a broad-spectrum antibiotic intravenously to address potential secondary bacterial infection and initiate continuous nebulized albuterol. Option C. Initiate high-flow nasal cannula oxygen therapy and administer a dose of oral dexamethasone to reduce airway inflammation. Option D. Administer supplemental oxygen to maintain saturation above 90%. Perform a thorough respiratory assessment, including auscultation and work of breathing evaluation, and consider inhaled bronchodilators if wheezing is significant and unresponsive to initial measures. The correct answer is D. Administer supplemental oxygen to maintain saturation above 90%. Perform a thorough respiratory assessment, including auscultation and work of breathing evaluation, and consider inhaled bronchodilators if wheezing is significant and unresponsive to initial measures. Explanation. Scenario analysis. This scenario presents a common pediatric emergency, bronchiolitis, where rapid assessment and appropriate intervention are critical. The challenge lies in differentiating between mild, moderate, and severe presentations, as well as recognizing potential complications. The nurse must balance the need for prompt treatment with avoiding unnecessary or potentially harmful interventions. The fluctuating nature of respiratory distress in infants adds to the complexity, requiring continuous reassessment and adaptation of care. Correct approach analysis. The correct approach prioritizes a systematic assessment of the child's respiratory status, including vital signs, work of breathing, oxygen saturation, and auscultation findings. This aligns with established pediatric emergency nursing guidelines, such as those promoted by the Emergency Nurses Association (ENA) and the American Academy of Pediatrics (OP), which emphasize a thorough physical examination and objective data collection. The use of supplemental oxygen based on SpO2 levels and the administration of bronchodilators, if indicated by the assessment, are evidence-based interventions for moderate to severe bronchiolitis. This approach is ethically sound, adhering to the principle of beneficence by providing necessary care, and professionally responsible by following best practices to ensure patient safety and optimal outcomes. Incorrect approaches analysis. Administering a broad-spectrum antibiotic without evidence of bacterial co-infection is a regulatory and ethical failure. Antibiotics are ineffective against viral infections like bronchiolitis and contribute to antimicrobial resistance, violating guidelines for judicious antibiotic use. Relying solely on parental report of symptoms without a comprehensive physical assessment is professionally unacceptable. Pediatric emergency nursing standards mandate a direct, hands-on assessment to validate subjective complaints and identify objective signs of distress. This approach risks misdiagnosis and delayed or inappropriate treatment, potentially violating the duty of care. Initiating continuous nebulized albuterol without assessing the child's response or considering alternative therapies is also problematic. While bronchodilators can be helpful, their indiscriminate use in bronchiolitis is not universally supported by evidence, and overuse can lead to adverse effects. This approach may not represent the most efficient or effective use of resources and could delay other necessary interventions. Professional reasoning. Professionals should employ a structured approach to pediatric emergency assessment, starting with a primary survey, airway, breathing, circulation, disability, exposure, followed by a secondary survey. This systematic process ensures all critical areas are evaluated. For respiratory distress, this includes assessing the severity of work of breathing retractions, nasal flaring, grunting, auscultating lung sounds for wheezes or crackles, and monitoring oxygen saturation. Evidence-based guidelines for conditions like bronchiolitis should be consulted and applied. Continuous reassessment is paramount, as a child's condition can change rapidly. Collaboration with the physician and clear communication of findings are essential for timely and appropriate treatment decisions. Question 17. Strategic planning requires a pediatric emergency nurse to anticipate and manage emergent conditions effectively. A 3-year-old child presents to the emergency department with a witnessed generalized tonic-clonic seizure lasting approximately 4 minutes, accompanied by a temperature of 103.5 degrees F, 39.7 degrees C. The child is postictal but still exhibiting some twitching. Based on current pediatric emergency nursing guidelines and the immediate need to control seizure activity, which pharmacological intervention is the most appropriate initial step? Option A. Administer oral acetaminophen 15 mg/kg. Option B. Administer intramuscular diphenhydramine 1 mg/kg. Option C. Administer intravenous normal saline 10 ml/kg bolus. Option D. Administer intravenous lorazepam 0.1 mg/kg. The correct answer is D. Administer intravenous lorazepam 0.1 mg/kg. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in pediatric emergency care, managing a febrile seizure in a young child where the initial presentation is ambiguous regarding the underlying cause and the appropriate pharmacological intervention. The nurse must rapidly assess the situation, consider potential etiologies beyond a simple febrile seizure, and select a medication that is both effective and safe for the pediatric population, adhering to established protocols and evidence-based practice. The urgency of the situation, coupled with the vulnerability of the patient, necessitates swift, accurate, and ethically sound decision-making. Correct approach analysis. Administering intravenous lorazepam is the best professional practice in this scenario. Lorazepam is a benzodiazepine that is a first-line agent for the acute management of pediatric seizures, including febrile seizures, due to its rapid onset of action and efficacy in terminating seizure activity. Its use is supported by numerous pediatric emergency medicine guidelines and is considered a standard of care. The intravenous route ensures rapid delivery to the central nervous system, which is crucial in an emergency setting to prevent potential neurological sequelae from prolonged seizure activity. Adherence to the prescribed dose, based on the child's weight and age, is paramount and aligns with regulatory requirements for safe medication administration in pediatric patients. Incorrect approaches analysis. Administering oral acetaminophen is an incorrect approach because while it addresses the fever, it does not directly treat the ongoing seizure activity. Acetaminophen is an antipyretic and analgesic, not an anticonvulsant. Delaying anticonvulsant therapy while administering an antipyretic could lead to prolonged seizure duration, increasing the risk of secondary injury and complications. This failure to address the immediate life-threatening condition constitutes a breach of professional duty and potentially violates standards of care for emergency nursing. Administering intramuscular diphenhydramine is also incorrect. Diphenhydramine is an antihistamine used for allergic reactions. It has no anticonvulsant properties and would be ineffective in stopping the seizure. Administering a medication with no therapeutic benefit for the presenting condition, especially when a known effective treatment exists, is a significant deviation from best practice and could be considered negligent. Administering intravenous normal saline bolus without an anticonvulsant is incorrect because it fails to address the primary emergency. While fluid resuscitation might be indicated if the child is dehydrated or hypotensive, it does not terminate the seizure. The immediate priority is to stop the seizure activity. Relying solely on supportive care, without administering a targeted anticonvulsant medication, is a failure to provide appropriate emergency management. Professional reasoning. When faced with a pediatric patient experiencing a seizure, the professional decision-making process involves a rapid assessment of the ABCs: airway, breathing, circulation, identification of the immediate threat seizure activity, and prompt administration of evidence-based interventions. This includes consulting established pediatric emergency protocols and drug formularies, considering the patient's age and weight for appropriate dosing, and selecting the most effective route of administration for rapid therapeutic effect. Ethical considerations include the duty to act in the best interest of the child, minimizing harm, and providing competent care. In this case, the immediate goal is to stop the seizure, making an anticonvulsant the priority over symptomatic treatment of fever or supportive measures alone. Question 18. Analysis of a 4-year-old child presenting with severe respiratory distress, characterized by marked retractions, grunting, and diminished breath sounds. What is the most appropriate initial PALS-guided intervention to address the immediate life threat? Option A. Auscultate lung sounds to confirm the extent of respiratory compromise before any intervention. Option B. Administer high-flow oxygen via nasal cannula and monitor vital signs closely. Option C. Obtain peripheral intravenous access and administer a bolus of intravenous fluids. Option D. Initiate bag valve mask ventilation with supplemental oxygen while preparing for advanced airway management if indicated. The correct answer is B. Administer high-flow oxygen via nasal cannula and monitor vital signs closely. Explanation. Scenario analysis. This scenario is professionally challenging due to the critical nature of pediatric emergency care, where rapid and accurate assessment and intervention are paramount. The nurse must navigate the complexities of PALS protocols, which are evidence-based guidelines designed to standardize care and improve outcomes for critically ill or injured children. The challenge lies in applying these protocols effectively in a high-pressure environment, considering the child's specific presentation, potential underlying etiologies, and the need for timely, appropriate interventions while maintaining patient safety and adhering to regulatory standards for pediatric emergency nursing. Nurses' judgment is crucial in differentiating between conditions that require immediate, aggressive PALS interventions and those that may be managed with less intensive measures, all while ensuring the child's well-being and upholding professional responsibilities. Correct approach analysis. The correct approach involves a systematic assessment guided by PALS algorithms, prioritizing airway, breathing, and circulation, ABCs. This aligns with the core principles of PALS, which emphasize a structured, evidence-based approach to resuscitation and stabilization. Specifically, recognizing signs of respiratory distress and initiating appropriate interventions such as oxygen therapy, bag valve mask ventilation, or advanced airway management, as indicated by the child's condition and PALS guidelines, represents best professional practice. This approach is directly supported by regulatory frameworks governing pediatric emergency nursing, which mandate adherence to established resuscitation protocols to ensure optimal patient care and outcomes. Ethical considerations also dictate that the nurse act in the best interest of the child, which is achieved by following these validated protocols. Incorrect approaches analysis. One incorrect approach would be to delay definitive airway management despite clear signs of impending respiratory failure, such as retractions, grunting, and decreased air entry, in favor of less invasive measures that are not supported by PALS guidelines for such severe presentations. This failure to adhere to PALS protocols constitutes a regulatory and ethical lapse, as it deviates from established standards of care designed to prevent further deterioration and improve survival. Another incorrect approach would be to administer medications without a clear indication or in doses not recommended by PALS, potentially leading to adverse effects or ineffective treatment. This violates the principle of providing evidence-based care and could be considered a breach of professional responsibility and regulatory compliance. A third incorrect approach would be to focus solely on obtaining intravenous access before addressing critical airway and breathing issues, as PALS prioritizes immediate life-saving interventions for ABCs. This misprioritization can lead to irreversible harm and is contrary to the fundamental tenets of emergency resuscitation. Professional reasoning. Professionals should employ a decision-making process that begins with a rapid primary survey, ABCs, followed by a secondary survey. This process should be informed by a thorough understanding of PALS algorithms and a continuous reassessment of the child's condition. When faced with uncertainty, consulting with experienced colleagues or supervisors and referencing PALS guidelines promptly are crucial steps. The decision-making framework should prioritize patient safety, adherence to evidence-based protocols, and clear, concise communication among the healthcare team. This systematic and protocol-driven approach ensures that interventions are timely, appropriate, and aligned with regulatory and ethical expectations for pediatric emergency care. Question 19. Cost-benefit analysis shows that implementing a comprehensive pediatric adverse drug reaction surveillance and reporting system, including enhanced staff training and rapid response protocols, incurs significant upfront investment. However, when a pediatric emergency nurse identifies a potential adverse drug reaction to a newly administered medication in a critically ill child, which of the following actions best aligns with the immediate regulatory and ethical imperatives for patient safety and professional practice? Option A. Prioritize reporting the incident to the hospital's risk management department to initiate a formal investigation before intervening with the patient. Option B. Focus on documenting the suspected adverse drug reaction in the patient's chart and wait for the physician to provide specific instructions before taking any action. Option C. Continue administering the medication at a reduced dose while awaiting further laboratory results to confirm the adverse reaction, to avoid disrupting the treatment plan. Option D. Immediately discontinue the suspected medication and initiate supportive care as per institutional protocols, while notifying the physician and documenting the event thoroughly. The correct answer is D. Immediately discontinue the suspected medication and initiate supportive care as per institutional protocols, while notifying the physician and documenting the event thoroughly. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the pediatric emergency nurse to balance immediate patient safety with resource allocation and potential long-term implications of medication errors. The nurse must quickly identify and manage an adverse drug reaction ADR in a vulnerable pediatric patient, while also considering the broader impact on the healthcare system and the family's trust. The complexity arises from the need for rapid assessment, accurate diagnosis of the ADR, appropriate intervention, and effective communication with the medical team and family, all within the high-pressure environment of the emergency department. Correct approach analysis. The correct approach represents best professional practice by prioritizing immediate patient safety and adhering to established protocols for ADR management. This aligns with the core ethical and legal responsibilities of a pediatric emergency nurse, which include the duty to prevent harm and act in the best interest of the child. Specifically, this approach would involve immediate cessation of the suspected offending medication, prompt administration of appropriate antidotes or supportive care as per institutional guidelines and physician orders, and thorough documentation of the event. This is directly supported by nursing practice standards and regulatory frameworks that mandate vigilant monitoring for ADRs and prompt intervention to mitigate harm. The focus on evidence-based practice and adherence to the nursing process, assessment, diagnosis, planning, implementation, evaluation, ensures a systematic and safe response. Incorrect approaches analysis. One incorrect approach would be to delay intervention or continue the suspected medication while awaiting further diagnostic confirmation. This represents a significant regulatory and ethical failure. Ethically, it violates the principle of non-maleficence, do no harm, by potentially prolonging the child's exposure to a harmful substance. Legally and regulatorily, it could be considered a breach of the standard of care, potentially leading to patient harm and subsequent legal repercussions. Another incorrect approach would be to focus solely on the financial cost of managing the ADR without adequately addressing the immediate clinical needs of the child. This is an ethical failure as it prioritizes economic concerns over patient well-being, which is unacceptable in healthcare. Regulatory frameworks consistently emphasize patient safety and quality of care as paramount, and any approach that compromises these for financial reasons is a direct violation. A third incorrect approach might involve blaming the prescribing physician without engaging in collaborative problem-solving and immediate patient care. While accountability is important, the immediate priority in an emergency setting is the patient's stability. Failing to act swiftly to manage the ADR while engaging in blame is a failure in professional responsibility and teamwork, potentially delaying critical interventions and impacting patient outcomes. This can also lead to a breakdown in interprofessional communication, which is vital for patient safety and regulatory compliance. Professional reasoning. Professionals should employ a systematic decision-making process that begins with rapid patient assessment and identification of potential ADRs. This involves a thorough review of the patient's medication history, current medications, and presenting symptoms. Upon suspicion of an ADR, the nurse should immediately consult institutional protocols and the prescribing physician. The decision-making process should prioritize evidence-based intervention, patient safety, and clear, concise communication with the healthcare team and the patient's family. Documentation should be meticulous, capturing all assessments, interventions, and patient responses. Continuous monitoring and reevaluation are crucial to ensure the effectiveness of interventions and to identify any new or evolving issues. This process is guided by professional codes of ethics, nursing practice acts, and institutional policies designed to ensure safe and effective patient care. Question 20. Risk assessment procedures indicate a 4-year-old child presenting to the pediatric emergency department with stridor, retractions, and cyanosis, suggesting significant upper airway obstruction. The nurse has initiated oxygen therapy and is preparing for potential airway intervention. Which of the following actions best reflects the immediate priority in managing this pediatric patient's airway? Option A. Administering a racemic epinephrine nebulizer treatment and preparing for potential intubation. Option B. Immediately attempting endotracheal intubation to secure the airway. Option C. Administering a sedative to calm the child before further assessment. Option D. Providing continuous bag valve mask ventilation while awaiting physician arrival. The correct answer is A. Administering a racemic epinephrine nebulizer treatment and preparing for potential intubation. Explanation. Scenario analysis. This scenario is professionally challenging because it involves a critically ill pediatric patient with a compromised airway, requiring rapid and accurate assessment and intervention. The nurse must balance the urgency of the situation with the need for precise, evidence-based airway management techniques. Considering the unique anatomical and physiological differences in pediatric patients compared to adults, the potential for rapid deterioration necessitates a systematic approach to ensure patient safety and optimal outcomes. Correct approach analysis. The correct approach, which involves a structured assessment of airway patency, oxygenation, and ventilation, followed by the selection of an appropriate airway adjunct or advanced airway intervention based on the patient's presentation and the nurse's skill set, represents best professional practice. This aligns with established pediatric emergency nursing guidelines, such as those promoted by the Emergency Nurses Association (ENA) and the American Heart Association (AHA) Pediatric Advanced Life Support (PALS) protocols. These guidelines emphasize a systematic approach to airway management, prioritizing interventions that ensure adequate oxygenation and ventilation while minimizing the risk of complications. The nurse's responsibility includes recognizing signs of airway compromise and initiating appropriate interventions within their scope of practice, escalating care as needed. Incorrect approaches analysis. One incorrect approach would be to immediately attempt intubation without a thorough assessment of the airway and the patient's overall condition. This could lead to unnecessary delays in providing oxygenation and ventilation, potentially causing further hypoxia and patient harm. It also bypasses crucial steps in the PALS algorithm for airway management, which prioritizes less invasive interventions first if appropriate. This failure to follow established protocols constitutes a deviation from best professional practice and could be considered a breach of the standard of care. Another incorrect approach would be to rely solely on bag valve mask (BVM) ventilation for an extended period in a patient with clear signs of impending airway obstruction or inadequate ventilation, without considering or preparing for advanced airway interventions. BVM is a critical initial step. Prolonged reliance without reassessment or escalation, when indicated, can lead to inadequate gas exchange and patient decompensation. This demonstrates a failure to recognize the limitations of BVM and to progress to more definitive airway management as dictated by the patient's clinical status, potentially violating guidelines that advocate for timely advanced airway placement when necessary. A third incorrect approach would be to administer sedatives or paralytics without first securing the airway or ensuring adequate oxygenation and ventilation. This is a critical safety failure, as these medications can further compromise respiratory effort and mask signs of distress, making subsequent airway management more difficult and dangerous. This action directly contravenes fundamental principles of airway management and patient safety, representing a significant ethical and professional lapse. Professional reasoning. Professionals should utilize a systematic decision-making process that begins with a rapid primary survey, ABC's airway, breathing, circulation. For airway management, this involves assessing for patency, identifying obstructions, and evaluating the effectiveness of breathing. Based on this assessment, the nurse should consider the least invasive effective intervention first, such as positioning, suctioning, or the use of an airway adjunct e.g., oropharyngeal or nasopharyngeal airway. If these measures are insufficient, or if the patient presents with severe distress or inability to protect their airway, the nurse must be prepared to proceed with advanced airway interventions, such as supraglottic airway devices or endotracheal intubation, in accordance with PALS guidelines and institutional protocols. Continuous reassessment of the patient's response to interventions is paramount. Collaboration with the physician and other team members is essential, especially when considering advanced interventions or if the patient's condition deteriorates.